Good afternoon, everyone. I'm delighted to be here today to share my work on centering diverse voices in priority setting for hand osteoarthritis and to reflect more broadly on how effective knowledge translation and mobilization really begins at the design stage through patient co-design.
Thank you, Dimitra. Could you please describe yourself before you launch into your content?
Yes. So I am a white woman in my early 30s. I have ginger hair and I'm wearing a red sweater. Today I'll be walking you through the process that I followed in developing an evidence-based technology-enabled joint protection program for people living with hand osteoarthritis. And how each step was guided by principles of co-creation, inclusion, and usability. So when we talk about knowledge translation and mobilization, we often think about dissemination and how we move research findings into practice. But true knowledge translation and mobilization starts much earlier during the design of the research itself. So this is the shift from doing research on people on doing research with them. And in health research, this means that that the end users, the patients, the clinicians, the caregivers, they aren't simply recipients of our fundings, but they help shape what questions we ask, how we collect data, and how the final intervention looks and feels. This co-design approach strengthens every part of our knowledge to action cycle, and it ensures that what we produce is not only evidence-based, but also meaningful, usable, and equitable. And that is particularly important in conditions like hand osteoarthritis, where treatment options are limited and patients have historically been underrepresented in decision-making. So why center diverse voices? Well, hand osteoarthritis is one of the most common musculoskeletal conditions, and yet it receives far less attention than knee or hip osteoarthritis. It causes pain, stiffness, loss of hand function. It can affect daily tasks like dressing, cooking, or typing. But beyond the physical symptoms, there is a deeper equity issue. We know that women, older adults, immigrants, people in rural areas, and those with caregiving roles all experience barriers, not only to treatment, but also to being heard. Their priorities and experiences rarely make it into the intervention design. So centering diverse voices isn't just good practice, it's a matter of fairness. If we want to close knowledge translation gaps, we have to start by asking whose voices are missing and how can we bring them in? And that's the question that motivated my doctoral research. So the first step was to map what already exists. So we conducted a scoping review of patient involvement in the design of joint protection programs for hand osteoarthritis. And the first barrier that we found was that there was not really, even though there is a lot of published literature in how to do patient co-design, we couldn't find a tool that we could use to map the process. So the first step was to design some operational definitions to be able to assess whether the included studies used patient co-design in every stage of the process, starting from the conceptualization phase, where we're looking at active engagement of patients in shaping the purpose and priorities of the study, to intervention design, where we're looking at patient involvement in shaping the content, the format, and the delivery of the intervention, iterative feedback and refinement, including repeated cycles of patient feedback that influence revisions to content, structure, or delivery. And finally, using patients as co-facilitators or co-deliverers as well. And finally, we created a category for minimal post hoc involvement, just to facilitate our own research and to have an item to code for studies that they only consulted patients in a post hoc manner without clear influence on the intervention design, which does not meet the minimum requirements to be considered as efficient patient co-design. Out of 32 studies that we included, most did not report any patient involvement at all. And when patients were involved, their participation was usually post hoc. For example, providing feedback after the intervention was already developed. Only 8 out of 32 studies explicitly included patients as co-designers, and none engaged them through all stages from conception to evaluation and delivery. So even though joint protection is a cornerstone of self-management in hand osteoarthritis, the way we teach it hasn't meaningfully evolved with or for patients. So this study gave us clear direction. We wanted to build a truly patient-centered joint protection program, and we needed to start from the ground up by asking patients what they find difficult and what they value the most. So the second step was to do an elicitation of diverse patient priorities. And to do that, we did a mixed method study designed to identify and understand what daily activities people with hand osteoarthritis find more challenging and why. And this included an online survey and follow-up interviews using interpretive descriptive design. And the survey helped quantify which tasks like opening jars, gripping, or typing were the most problematic. But the interviews went deeper, revealing how these difficulties intersected with people's social roles and identities. For instance, participants living in rural areas described challenges using adaptive devices that simply weren't available in local stores. Those with caregiving responsibilities spoke about prioritizing others' needs over their own pain. And immigrant participants often discussed language barriers and limited access to therapy. So another thing that connected the two studies, the survey with interviews, is that we did use the surveys to purposefully recruit patient groups that they are underrepresented in research. And by intentionally recruiting underrepresented groups, we were able to explore how intersectionality shapes both the symptom experience and access to self-management strategies. And if you want to read more about how we did this study and the methods, this study is published in Nature Scientific Reports, and it is open access. So feel free to check this out. Moving on, we wanted to quantify what matters, and building on that qualitative foundation, what we wanted to do is quantify patient preferences. And this was especially important as we were designing an intervention that we were expecting to have a large-scale implementation. To do that, we used a discrete choice experiment, or DCE, which is a structured method where participants choose between hypothetical program options that vary across features like session format, support, and level of clinician interaction. And it is a unique way that allows us to assess patients' priorities and trade-offs. Before developing the survey, we conducted focus groups to identify which features were the most important to patients. And then using a larger online sample, we examined how different groups valued those features. Our results suggested that when it comes to the delivery of the program, there wasn't a one-size-fits-all solution. Some participants prioritized flexibility and self-paced learning, Others preferred having live clinician contact, even if it meant having higher time commitment. So this reinforced the need for a modular, customizable digital program that would allow people to engage in ways that fit their lives, their health literacy, and their resources. So in terms of the integration of the findings, at this point, we had 3 layers of evidence. So the literature review showed limited patient engagement, the mixed method study revealing real-world barriers and priorities, and the discrete choice experiment quantifying how much people value different delivery features. And bringing this together, we created the foundation for the next phase, the development of our joint protection program. And this integration wasn't just about combining data, it was about aligning the principles of knowledge translation and patient co-design. In other words, we were moving from evidence synthesis and patient voice to actual intervention creation. So here's a brief look at the resulting program. We call it Helping Hand, and it is organized in 6 interactive modules, 4 asynchronous modules, and 2 live modules. And I'm going to share part of the program with you, but before I do that, I'll just highlight the core philosophy here. So every element was designed with and for patients. The program opens with 2 educational videos explaining what is hand osteoarthritis and what joint protection means in principle, using a simple, friendly language. And then subsequent models guide users through pacing, prioritizing, and ergonomic adaptations. And rather than having a passive lecture, the participants can interact with clickable rooms. We have an interactive house in module 3, where they can go through a kitchen or a bedroom or an office and learn task-specific activities. To fully align with the operational guide that we created in the beginning, we also included patient-recorded stories, where we invited a patient partner who expressed interest to have a more active role in the creation of the intervention to talk about their experience, and this is part of the program now. And we are also including live Q&A sessions with clinicians and a community of practice where people that participate in the program get together and discuss about their own experiences. Okay, so at this point, I'm going to share my screen. So this is the platform of the program, and we really tried to keep the video short. We have captions in all of the videos, and we also mention how long the video is before in the first page, so that the patients can see what they're signing up for. And I'm just gonna play this video right here, which is the part about what is prioritizing, so that you can get to see what it looks like.
Focus on prioritizing, the second key strategy to protect your joints. What is prioritizing? Prioritizing is about choosing what's most important and letting go of the less critical tasks when your hands are feeling sore. Some days, you might not be able to do everything on your to-do list, and that's okay. Prioritizing sometimes means choosing ease over strain. Letting the floors wait a little longer, keeping meals simple, or leaving the bed unmade can free up energy for the things that bring joy. These small changes aren't about lowering standards, they're about protecting your joints and giving yourself more space to enjoy the things that matter most. To prioritize effectively, I like to use the 3 Ds: do, delegate, and delay. Do, focus on the tasks that are absolutely necessary. Delegate, if possible, ask someone for help with tasks that are hard on your hands. Delay, if a task isn't urgent, consider postponing it to another day when your hands feel better.
And another part I would like to share is the interactive house activity. to see what it looks like. So we have an outline of a house where you can see different rooms throughout 2 different floors. And then people can click in different rooms, for example, the hallway, and then there are markers that they can click on. And there are short videos about, for example, using keys.
Using keys. Key turners or keys with larger, ergonomic grips minimize the need for tight pinching and twisting. This design enables you to use a relaxed, full-hand grip that keeps your wrist straighter and engages larger joints, thus distributing effort evenly and reducing repetitive strain on your fingers.
Yeah, I'm just going to click in a few more rooms so that you get to see how it looks like. We have the instructions on how to navigate on the top right corner, and getting through the purple markers, you get to see what each content is, and then you can click on the video. And finally, we have the module with the patient partner, which is basically a video of the patient talking about their experience. And I'm gonna stop sharing at this point and get back to the presentation. Okay, so translating evidence into action. So how did we test whether this co-design program actually worked in practice? That brings me to step 4 and 5, the translation and implementation phases. So first, we conducted usability testing. And to do that, we used an iterative patient co-design, which means that each participant was presented with the latest version of the app. And based on the comment, we would of the program, and then based on their comments and their feedback, we were making adjustments to the app, and the next participants would be presented with the newest version, and so on. The sessions combined think-aloud protocols, eye tracking technology, independent task completion, and a final debrief where patients got the chance to assess the clarity and the relevance of the content, including a formal health literacy assessment of the program itself. And participants navigated the platform while sharing their thoughts out loud, allowing us to identify points of confusion or accessibility barriers. This process provided feedback on usability features. For example, some buttons were hard to see for people with visual impairments, or video subtitles needed clearer contrast, and each iteration improved inclusivity and user experience. And here you can see how the user experience improved as we went through with the program. It's a chart where there is blue and red color, and red color means usability issues, and blue color means optimal use. And we had a number of different tasks that the participants had to complete, and these are only the results from the eye tracking. So what we did was we used a software to monitor the eye movement of the participants, and we searched for specific eye patterns that are showing better or less optimal engagement. And then we rated their engagement with the platform. And starting from the first participant all the way to the left, where you see there are a lot of usability issues, going all the way to the end, where you see that there is pretty much optimal use of the app. And finally, we are now conducting a pilot feasibility trial at Ralph McFarlane Hand and Upper Limb Centre in London, Ontario. And this is an open label parallel group randomized design testing the acceptability of the program and the feasibility of running a full scale trial. We are tracking metrics like recruitment, adherence, attrition, and data completion at baseline for 8 and 12 weeks. Beyond the numbers, the acceptability assessment captures what knowledge translation should achieve, knowledge that people can see themselves in and they can apply in their own context. A few information for the trial. So it is designed as a mini version of the full trial where the primary outcome would be pain intensity. We're also going to assess function, adoption of joint protection strategies, and quality of life. And we're currently recruiting for this trial. So if you know anyone living in Canada that would be interested, please feel free to contact us. It doesn't matter whereabouts in Canada they are, because the trial is fully remote, so they can join from anywhere in Canada. And at this point, I would like to go back to what I was saying about this process and how this process has built lasting infrastructures. So we've built partnerships with patient partners, clinicians, and community networks who now have the tools and relationship to co-create future intervention. And that's a broader knowledge translation impact, not just creating one program, but changing how we create patient education programs. And knowledge translation isn't really a final step. It's a thread that runs through the entire research process, and patient co-design is where that thread begins. By embedding patient voices from the start, we don't just make research more relevant, we make it more just. And we move from translating knowledge to people to translating knowledge with them. This approach is especially crucial in rehabilitation, where lived experiences shape every aspect of treatment adherence, accessibility, and outcomes. So when we talk about knowledge translation impact or implementation success, perhaps the real question is, did we start by listening? And as I close, I'd like to leave you with this thought. If we want to make our interventions equitable, scalable, and sustainable, we have to continue designing with patients and not for them. And a question that we need to keep asking is, who's not at the table yet, and how can we invite them in? Thank you so much for your time, and I'm happy to take any questions.
Great, thank you, Dimitra. So there's been a lot of chat, already even before your presentation, between Bonnie Zink and Paula Robeson, really pointing out that the process you're using, patient co-design, is a great example of knowledge translation and knowledge mobilization. So I think they are, cheerleading and echoing your overarching message. So there are some questions for you. People are very excited about this resource. Some people in the audience actually have hand arthritis. Is this available to the public already, or not, because you're still studying it?
We are still studying it. Once we test its effectiveness, then it will be freely accessible. And this was a goal that we had from the beginning. At some point we had opportunities for commercialization, but we really just wanted to have something that would be available free for everyone. So we decided to not go that way. So eventually, once we test that it's actually effective and it's actually helping people with hand arthritis, yes, it will be available to everyone.
Fantastic. And obviously, you did and are doing very thorough usability testing of the tool, but can you talk more about accessibility of the tool? So for example, someone pointed out the graphic of the house map. Is that something that interacts with screen readers well, or not so much?
So far, we've only tested accessibility in terms of hearing impairments and not visual impairments. So this is something that we continue to test in terms of visual impairments.
And of course, that image appears in this deck. And when we distribute the deck, it will have an alt tag. So I don't know if they would have just marked it decorative. I didn't look at all the alt tags, but you may be able to lift that in case it's useful. And so what program did you use to make it? What software?
We used Beyond. It's a very nice program. Unfortunately, it's a program that you have to pay for. And this circles back to everything we were discussing before about the cost. But we really like it because you can use AI to generate a lot of the content. And then you can also use AI to translate in other languages as well, which is another step that we would like to take. Of course, we're not going to rely just on AI to do the translation, and we're going to have native speakers looking into that. But having to review something would take a lot less time than having to translate something from scratch. So we really like that Beyond offers that opportunity. And right now, I served it in Articulate. So this is the platform that is hosting it right now before it transitions to our hospital website.
Okay. So you used Articulate Rise and to make
Beyond.
Is that spelled correctly? Vyond, the program that you used?
Byond, yes, Beyond.
Okay, thank you. And in the video, this is another like specific question about an accessibility feature. Does the text change based on the browser settings? Do you know, or is that kind of in the weeds for you?
So we've tested in different mobile devices, tablets, and laptops. I'm not quite sure if that's what you mean by browser, but we know that the font changes like when it comes to phones, and it is like a good readable size. At least that's the feedback that we got from the users that were using mobile phones to access it.
Thank you. I think a browser is like Google Chrome or Safari.
Okay, so we did have some issues. The reason why the house, for example, is in 2 floors is because the program was too heavy when it was in 1 floor, and there were certain people with low internet connection or with certain browsers that they are a little bit slower, that they could not load the program. So we did some adjustments there during the usability testing to make sure that it works with different browsers.
Okay, but you don't know yet, like if you change like that. Well, I guess people will just have to test it out.
We've tested Chrome, Safari, Internet Explorer. I think that's the 3 that we've tested. And Internet Explorer, I would say, in Safari were a little bit more challenging, but now we made it work with those 2.
Okay. And Brooke Cruz put in a link. Someone said, can we have a link for the study in the chat? And she added an article from Nature. Is that accurate? Was that?
I can double check that. You just scroll up.
It's your author, Understanding Patient Needs.
Yes. Yep.
Okay. Thank you, everybody.